For the agent that must be in the know, Medicare Industry Insider discusses critical insight, noteworthy trends, and upcoming issues in the Medicare market.
Deciphering and debating the legislation, regulation, and what's happening in the market. I'm Jalen Jackson.
And I'm Rachel Brameyer, and we're going to talk shop, dive deep into these complex topics, and make them understandable and actionable.
If you've ever wondered where the world of Medicare is going and how to prepare for the future, Medicare Industry Insider is the resource you've been looking for.
Welcome to another edition of Medicare Industry Insider. I am Rachel Brameyer.
And I'm Jalen Jackson.
And today we're going to go over the 2024 Prospective payment models, not specifically going into depth of just what options are available in this coming year. Every year CMS evaluates and makes changes to payment models. A lot of that's based on services provided. And I think the thing that we're going to discuss mostly today is that every year, I think the government goes back and forth of like who deserves to get paid, where does the money go, where should it benefit clients the most, and basically making sure that everything's the price cuts are in the right spots and people who deserve to get paid are ones who deserve to get paid. So we'll definitely go into a big debate on that today for sure.
Yeah. Well, and I think one of the things we want to start with is some of the payment adjustments. So looking at the inpatient prospective payment system for this year, definitely some changes going into that. And again, this is all just looking at who gets paid, what they get paid, how they get paid, and, you know, under what billing models. So looking at some payment reductions for readmissions, looking at changes to how they affect the worst performing quartile of some of these various performance metrics, and then just looking at value-based care and adjustments under that. And I think the big thing to remember with all of these different pay models is that there's a million things that interact with it. Just because a hospital is, for example, underperforming on their different performance metrics that CMS tracks does not always mean that they're going to get some of the payment penalties that they maybe should. One of the big things that we miss out on is there are a lot of kind of cost protected hospitals. So rural emergency hospitals and disproportionate share hospitals, any of these hospitals that are already in kind of these protected at-risk categories, a lot of times, even if they're not meeting quality metrics, they don't actually face any of these penalties on their payments because, why make a bad problem worse by cutting their pay? So it gets really complicated when a lot of these are designed to increase, or improve patient experience and, kind of keep hospitals honest about what they're doing, but then we actually can't penalize some of the worst performers because it will just make the problem worse. Yeah. So I think what we see is the mismatch of how we're incentivizing hospitals to provide better care, and some of these things are evident in the different payment models we'll discuss.
Yeah, and I think previous episode when we talked about a lot of the smaller rural hospitals, we actually did discuss that there was a lot that did not even fall into any sort of monitoring, which was interesting to look at because you're right. If you look at it, is it going to make the problem worse by causing them to have additional scrutiny and people looking at them? So I think that is interesting that while there is the inpatient prospective payment model system, that it doesn't apply to every hospital. So it's there. And some hospitals do get penalized, usually the bigger hospitals that are under scrutiny. So it is interesting to take a look at like the why behind that, just specifically this one.
Well, and I think one of the big things that affects some of those hospitals' performance is their payer mix. So, I mean, there's a lot of cross sections here. Obviously, we talk primarily about the Medicare program here, but if you're in the industry, you hear a lot about payer mix when it comes to providers. What percentage of their income is coming from Medicaid, original Medicare, Medicare Advantage, commercial insurance, ACA, or individual family plans. And they all have drastically different payment levels. And of course, we talk so much about Medicare, even in the context of payer mix, because Medicare is usually what most of those models are indexed off of.
Right. Yeah, they are. I mean, it's definitely the baseline of what almost every other model is based off of. So speaking of Medicare, another thing we wanted to go into is just payment differences of Medicaid, Medicare, and just original Medicare, and how doctors get paid. So obviously, doctors have to elect into Medicaid. So not every doctor accepts Medicaid. And it is something interesting because, it's a person who is low income. It allows them to go get care, but the network of doctors who accept it is so small that sometimes that's why it's important to go towards like a Medicare Advantage option to open up a bigger network for that particular person, because that doctor then will accept Medicare Advantage, maybe who doesn't accept Medicaid. So they need to make sure that they're actually handing their Medicare Advantage card and not their Medicaid card when they go see that doctor to get seen. So that gives, patients and physicians a wider range of patients that they could see and doctors that they can go to. But again, you're looking at a government paying or a third party paying, and which one pays faster, pays more. I think that's always the debate of like, what does a doctor want to accept?
Sure.
And why?
Well, and a lot of times there's, kind of external forces of that. It's really easy for a carrier, let's say they've got 50% of the market in a given county with in the local hospital. They go to that hospital and say, hey, we're going to renegotiate our contract for this year like we always do. Listen, right now, you're not accepting our dual eligible plan. You don't have a choice. It's an all or nothing game. You take all of our plans or you take none of them. Well, if that carrier has half the market, it's really tough for that hospital to say, well, we can afford to turn away that business just because we maybe don't want to deal with some Medicaid eligible individuals. Not to say it's not generally a good deal, so to speak, for the hospitals. You're probably, like you said, maybe going to see faster payments, maybe going to see higher payments than just Medicaid alone. The other big thing on the dual eligible side is just that ability to travel. And again, if you look at the demographics, Medicaid eligible individuals do tend to stay closer to home more often. But if someone has just Medicaid and original Medicare, they travel out of state, they're kind of on their own. Those Medicaid benefits do not cross state lines except in excruciatingly rare circumstances. So something like a Medicare Advantage plan can give them a lot more flexibility in addition to that.
Absolutely. Yeah, and it is interesting. You brought up a really good point of a lot of times the doctors are in a hospital network, and the hospital is the one negotiating prices with that Advantage plan or with the Medicaid plan. So they're kind of at the mercy of whatever that doctor network has negotiated.
Sure. And
what works best in terms of, payments and which ones are getting paid by as well. And then you've got the other layer where doctors then have their own, if they have their own practice outside of the hospital, maybe they work with both, their claims and billing person. What do they like and what do they not like? Sometimes it really just depends on the person who's in the office and the ease of utilizing that particular payment model.
Absolutely. I mean, just who's your staff comfortable working with? Who do they get prompt responses from? And, one of the things we keep seeing talked about in the news is prior authorization, step therapy, all of these kind of hurdles to care. So we're seeing a lot of preferences towards carriers that make that a little bit easier, either through, we've seen some news articles recently about carriers that are, discontinuing any prior authorizations on certain numbers of billing codes, just reducing the number of things that need that prior authorization. We've seen a lot of carriers start talking about gold carding, where high-performing providers won't have to go through prior authorization anymore as long as they maintain that high level of care. So I think as we look at how physicians get paid, I think the other side of that coin, in addition to the different different payers that are cutting checks, is what are the steps they have to go through to get paid. And it can be a long process. Yeah,
you've even got your specialist who then, if they're on an HMO plan, they've got to potentially have the primary care physician go back and approve it just that they can get the particular service that they want done approved as well. So you're talking about like all the steps they have to go through. The easier, we've even seen some hybrid HMO plans not require that. So you're completely right in terms of, payment models, in terms of physicians. There's a lot of hoops they have to jump through in addition to like what insurance options are available, but also the ease of access, how fast they get paid, what hoops they have to jump in just to get something approved.
Yeah.
So I think that kind of brings us to our next point, which is fee-for-service versus accountable care organizations. Everything we've talked about previously, like with Medicaid, Medicare, that's a fee-for-service type model, which is something that we've always done. We've talked about Medicare being the base.
Yeah.
Something that's been very interesting in the news and kind of a hot topic has been the accountable care organizations, because the debate is out right now if it's a better model of care, because that client then gets, the idea is that they'll get better care by having more connections with their organization. But I know you and I have talked about how then the hospital has to learn 2 different billing systems, and it just gets very, very confusing.
Well, and I think the biggest thing is ACOs, or value-based care. It's a lot more difficult for people to understand. Fee-for-service is easy. I do this procedure, or I have this product, and I get this price for it. Whereas value-based care has a lot more to do with what do the outcomes look like? Is it a savings compared to the old way of doing business? So looking at some of that, how much value are you providing to the client? It's almost
relative,
like if you were, it's so relative, and it would almost be like, if I went and cut someone's grass, and instead of getting paid for, however many hours it took me, I'm getting paid for how many stars they leave me on my Google review. And that's an excruciatingly simplified way to look at it, but there's a lot of kind of conflict in this model for, are people able to deliver higher value care, meaning better outcomes for fewer hospitalizations, fewer, skilled nursing stays? Are they able to actually provide that as a higher level of care while saving the Medicare program money, or do they provide that higher level of care by withholding care? And I think that's the big question that we're trying to be answered. Is there a way to manage care that does not involve withholding care? Because that's what we've seen for years and years. A lot of companies have been able to cut the cost of care, but they do so by limiting access. Yeah. And this is more about, how do we maximize access to care? And if we do that, does it save us money in the long run?
Yeah, and we've even seen, attempts to do that with, like, does the patient end up in the hospital again after 30 days? Yep. That's potentially a cut for the hospital. Are they, we've got the 3 midnight rule. Like, there's a lot of different things that have been attempted of, like, is this helping or hurting care in terms of the fee-for-service model of trying to get that, I don't know, just tweaked a little bit to get it to be the right balance. But the accountable care, you're right. Like the Google reviews, it's very simplified, but you're right. Like that's, how else do you describe it? Like it literally is value-based. And the whole point is making sure the community of doctors and care providers are working together to help better that patient's care. So how do you monitor that? How do you pay for that and make sure that it's
well, and especially because this is over time, and that's why we're currently seeing ACO models only launched in original Medicare. So if you look at things like the ACO REACH program or the new Make Care Primary model that'll be launching in the next year or so, these all focus on original Medicare because the time horizon is different. A lot of times these experimentation models do not work with, say, a Medicare Advantage plan because you've got a 1-year time horizon. You've got a contract year, and the terms can change year to year. Whereas Medicare, original Medicare, whether someone is a supplement or not is kind of irrelevant to the model, but it's the longer time horizon. There's actually been a lot of discussions in the space of ACOs and accountable care. What if we had a longer time horizon? What if we had a 3-year Medicare Advantage contract? Someone was stuck in their plan for 3 years. Is that long enough to see a major impact to quality of care and quality of life? Is that too long? Does it get people stuck? And it's a really fascinating thing. But the idea is, 1 year may or may not be enough time to have a significant positive impact on someone with multiple comorbidities, multiple chronic conditions, people who have delayed care for years because they couldn't access it. Is 1 year actually enough time to make an impact? And that's why, when you look at a lot of these trial models, a lot of them run for 10 years. And that doesn't mean every patient is in there for 10 years. They're all entirely voluntary programs. We still want people to have choice for care. But at the end of the day, 1 year probably isn't enough to get good data, to get good outcomes. And it's definitely not enough to see if it actually saves the program money in the long term.
Right. Yeah, I mean, it's definitely an interesting thing that we're going to be keeping our eye on to see if accountable care models take off or not, because we've definitely seen a lot of trial, like you just listed two off. So I want to pivot now to MACRA, because that was a past thing that we've seen, but it was from 2020. So anyone who the original thought behind it was the doc fix.
Sure.
So basically, kind of actually going to more of a accountable care type thought process where doctors were going to be cut fees or given option to get increases on Medicare based on how well their care was, particularly star ratings and reviews and things like that. That got taken on and off the table, I think, 16, 17 times. It was quite a few times.
Yep.
Before they ended up switching over to what we now know as a MACRA law that kind of adjusted any first dollar coverage options with Medicare. So you're looking at Plan F going away for people who were not eligible for Medicare prior to 2020. So that was one way for them to kind of cut some costs somewhere, and basically make the client responsible for the first dollar coverage with Plan G or any other plans that they pick up, but having that part be deductible regardless. So that was one of the major discussion topics with MACRA and the doc fix was, do we cut doctors? Is that going to hurt or harm them? Harm patients in general if we do this model? Or should we pivot and try to get money from Medicare in a different format, which is what they ended up doing?
Yep. Well, and I think so much of it goes back to this original idea of just levelizing the budget, managing overall Medicare costs to make sure that premiums aren't going up too drastically for Part B, to make sure that the Part A trust fund maintains, viability long term. So back in 2015, when they first passed MACRA and through its implementation up through 2020, we saw a lot of those changes. Physicians are up for fee cuts every single year, and it's the can that keeps getting kicked down the road by Congress. Not that they never get cuts, but it's the same thing. We get a proposed rule for fee cuts. It almost always gets reduced or changed or paused. Sometimes doctors do get the cuts that Congress promises them, but more often than not, we just kick the can down the road because doctors say, listen, we can't work under these conditions. What are we going to do? And as we keep looking at who is not getting paid, we keep seeing hospital pay go up. We keep seeing doctor pay go down. We see, a lot of other sides of the industry that are not facing those cuts. And I think that creates a lot of a lot of conflict in the provider industry. And, to what I'm almost skipping ahead a tiny bit, but site neutral payments has kind of been a big thing in the news the past couple of years, and this idea of charging the same fees for something regardless of where it's being delivered for entities that are owned by the same parent company. So you've got a hospital that owns an outpatient clinic, that owns a primary care clinic, that owns a radiology lab, making sure that the payments make sense. Should you really be charging that hospital administration fee at an outpatient clinic? And a lot of that has to do with things like MACRA, things like physician fee schedule cuts. They're trying to bake in additional fees that right now are perfectly legal, whether or not they're ethical is up for debate, I suppose. But trying to add in those fees to kind of make up for those cuts they're experiencing on the other side of the balance sheet. And I think that's something that everyone's been very, very concerned about. If you're not at a hospital, you should not be paying a facility fee. And that's kind of what the site neutral payments is about. Yeah,
and I think I'm okay skipping ahead and jumping into that because I think that does do a good segue from what we were just talking about. But so one of the big points was someone could go to a doctor and not actually go into a hospital, or we've even talked about teledocs, where maybe you call in, have a doctor conversation, and then all of a sudden you get this bill and it has like a fee for the facility. Why would it have it on there? But of course, it's because they need to keep the facility open, and like you would have normally gone to the facility if you hadn't done the teledoc option. So it is an interesting debate. We even see progress over that too, because one of the things that we referenced was over 10 years, site neutral payment policies could save Medicare up to $153 billion. So there's been a lot of studies and even beneficiaries up to $94 billion. So there's studies that have shown that it potentially could save Medicare a lot of money, which then, is this the right direction to go? It's always like you said, a give and take, a constant battle of where's the money going and why. So I think it is an interesting debate to see if we will see more site neutrality policies coming forward.
Well, and to be clear, like we've said on past episodes, Medicare is always going to be the test kitchen. That this is an issue, the site neutral payments is an issue across all levels of the industry, whether it's commercial payer, ACA, whatever the case may be. But Medicare is going to be the spot where it gets fixed, so to speak. I tell folks that Medicare is Congress's big stick that they can swing around, that, they can use that to really direct policy indirectly by making people ineligible for certain payments or changing payment policies with Medicare. They can really force change in the market as a whole, like we saw with insulin savings earlier this year. Medicare enacted a $35 cap on insulin for Medicare beneficiaries. The uproar from that caused many of the major insulin manufacturers to end up capping insulin for commercial and uninsured folks as well. So Medicare, again, just kind of test kitchen and the big stick, and it can really drive change to look at Medicare as the place to kind of create new ideas for how to pay people.
Yeah, so if they end up doing a site neutral payment, it would more than likely be the test kitchen would be Medicare if we decided to go that direction. So I think that's why they've been studying the actual cost savings specifically for Medicare. So it's interesting look at how we can kind of shift money around to make it work.
Sure.
Another thing that you and I had talked about was relative value units and the relative value sales update committee and how that works with making decisions in terms of what is actually they were looking at specific units relative to the organization as a whole in terms of service.
Well, and the committee is a really fascinating organization. So it's a kind of administrated by the American Medical Association in partnership with CMS. And this committee sets those relative value units, the relative value of a particular procedure compared to all procedures. Basically, how much is this particular procedure, what's a hip replacement worth compared to a heart catheterization, things like that. Yeah. And at the end of the day, those RVUs, relative value units, are used to set Medicare payment policy and determine what is that procedure worth in the Medicare fee-for-service system. So this committee gets together periodically, helps set these numbers, and some folks would say they do a great job, some folks would say they do a horrible job, but the makeup of the committee is the most interesting part to me. We talk a lot in this country and in this industry about primary care and what a struggle it is to find primary care doctors, to get them paid adequately, to get access to primary care for our clients. And, arguably one of the reasons for that is how relative value units are assigned. Of the 32 members on the RUC committee, only one of them is a primary care doctor. There's only one seat reserved for a primary care doctor, a couple seats reserved for internal medicine doctors. So by and large, the representation on that committee is specialists, which is fantastic. But when you're sitting there talking about, well, how much is my heart catheterization worth compared to what is a wellness visit worth, it's a tough argument to make when you've got 22 specialists sitting at the table with one primary doc, along with some other folks.
Or then making decisions on what trickles down into payment models.
Exactly.
Exactly. That's 100%. I think that is why there's a huge discrepancy too in terms of, which we wouldn't have known that if you didn't know about this particular committee and kind of where the prices actually come from. But the negotiations that everyone has, whether it be Medicare Advantage or Medicare itself, or, if we look at any other payment model like the ACA, they're looking at these relative value units and how much they're actually worth. So if you're looking at the primary care procedures, like whether it be going for a wellness visit or a welcome to Medicare visit or whatever a primary care visit would be worth compared to, getting back surgery or heart catheter or something like that, having one person represented out of 32, I don't think is fair personally, but It is interesting to see because that one person's got to represent all primary care.
Yep. Well, so let's talk about kind of the cost of doing business, and
Yeah.
everyone should know Rachel is incredibly biased about this because her dad was a doctor, but who since retired. But for providers, again, not only is this about how they get paid, but all of the expenses they have as well. Looking at malpractice insurance, looking at the cost of technology, electronic health records and things like that, security, not to mention the constant issues that everyone faces across all industries right now with hiring and staffing. Definitely a huge issue in seeing all of these payer pressures on providers and then increasing costs.
Right.
The two sides of the balance sheet keep getting closer and closer.
They do. It is interesting having the personal experience of seeing my own father being a doctor, but then also seeing friends of mine become physicians as well.
Sure.
And the differences in their mindset. So, my dad retired after 36 years of being a physician. When he started, the idea was you retire and you start your own practice.
Yeah.
You may do rounds in the hospital and potentially work for the hospital if you're primary care, because he was primary care. He chose to go his own business route. So he owned his own malpractice insurance. He had his own staff that he had to hire, his own building he had to keep track of. Little things like people coming into the office having an allergic reaction. Out of his own pocket, he had to keep EpiPens that, of course, expire. So he had to keep those just to make sure that when people went to his office and didn't, go to the ER, that he could save their life. So that was, again, like little weird things that you think of that are expenses. All the technology, whether it be phone systems, computers, fax machines, things like that, have to be out of the own doctor's pockets as well. Seeing the younger individuals who are going into their own practice now, very few of them are actually going into their own practice. A lot of them are working for doctors' offices because the cost of doing business is just so expensive now. So if you're looking at payment models and how does that reflect and how does that shift what the doctors are choosing to go, if a primary care physician, like we just talked about, is not getting paid for what is worth for them to run their business. I know that he mentioned, because I was almost thinking medical school when I went to college, and when I decided not to, that was malpractice insurance was actually something he was like, there are too many compliance regulations with the cost of doing business, because he mentioned even like cyber attacks.
Absolutely.
He had to carry additional insurance that he didn't have to carry when he initially started. The cost of record keeping and keeping things safe, malpractice insurance, literally everything had gone up. And he was like, that takes the fun out of doing what I want to do, which was saving people's lives and being a good doctor. Like that was his passion. And the rest of it was just added on top of the day-to-day. So it is interesting to see the younger group pivoting more towards being a employee of a hospital. Because it's just so expensive now.
Absolutely. I think it's just a lack of options. And, on the other side of that coin, there are people that are, to an extent, just opting out of the system altogether. We've got, a growing number of doctors that are pursuing something, call it what you want, concierge medicine, direct primary care, kind of that fee-based model where folks are paying a monthly membership and they're not even billing Medicare. They're not billing insurance.
They'd rather have cash or have like a retainer fee. I've seen several doctors go that direction. Yeah,
absolutely. So, a lot of folks kind of going towards that model where it's, membership fee plus direct costs or, slight markup on any, actual materials they use or prescriptions, and just trying to figure out what these new ways of doing business are. All of them great, all of them having potential to do good and bad for certain clients, I think.
Yeah, and I think as an agent looking at your local area, take a look at what hospitals are available, what doctors are available, and what payment models they accept or what they're opting into. Because like you said, several of them are choosing to opt out of any insurance-based pay or going with the retainer option or cash-based only. Just kind of totally throwing their hands up and saying, we're getting out of it. So I think as an agent, taking a look at what is available, who is available, even for Medicaid, like some doctors choose not to accept Medicaid. And, that's an important thing to know as an agent in your local area. So I hope today's prospective payment model discussion gave you a little bit more insight of how not only doctors and hospitals are paid, but also kind of the why behind it and the constant debate of who deserves to get paid and why. So thank you so much for watching this episode of Medicare Industry Insider, and we'll catch you next time.